Hi everyone, this is Professor Nicholson lecturing on the role of the nurse providing peripheral IV therapy. IV means intravenous. Please review this unit and module's sub-competencies on your own. Some people associate IVs with serious illness, but studies do show that approximately 75% of all hospitalized patients have an IV. The purposes of peripheral IV therapy on this slide are scenarios of patients who would most likely receive peripheral IV therapy. Of course, there can be more than what is listed depending on the patient situation, of course. Regarding resting the GI tract, the last one on the list, this could be due to nausea, vomiting, diarrhea, and ileus, which is a twisted bowel that can occur after bowel surgery, bowel obstruction, etc. This is why it is important for post-operative patients to start low and go slow when starting to eat or drink again. Always follow your provider orders. So what are the types of IV therapy? Continuous IV therapy is the method of delivering medication or fluids steadily into the bloodstream for an extended period, often several hours or even days. Whereas intermittent IV therapy, also known as an intravenous piggyback, is a method of delivering a specific volume of fluid, often containing medication, over a set period of time at prescribed intervals. Please know the name of an IV delivery type is classified by the location of the catheter's tip, not where it is inserted into the skin. Central venous access devices, also known as central lines, are thin, flexible tubes inserted into a large vein, typically in the neck, chest, arm, or groin, to provide long-term access for administering medications, fluids, or blood products, as well as for drawing blood. Central lines are used when a person needs intravenous therapy for several weeks or more, so this is long-term. Peripheral lines are when the catheter lies in the peripheral veins, and these lines are for short-term use. Other types are peripherally inserted central catheters, also known as PICC lines, in which the central end of the catheter, after placement, lies within the superior vena cava of the heart. This is for long-term infusions as well as highly concentrated solutions, such as chemotherapy. Midline catheters are another classification. These are 3 to 8 inches long, and these are inserted into the upper arm. Specialized forms of infusion therapy to be aware of, but you do not need to know, include subcutaneous, intraosseous, intraarterial, intraspinal, as well as intraperitoneal. So what is a medlock/saline lock? These are terms you may hear interchangeably in your facilities, but in the simplest terms, it is when the IV site is capped off from a line. Facilities have policies surrounding the frequency of flushing these, as well as the frequency of assessing for patency as well. Always make sure these sites are clean and visible, as we will discuss later. Notice where the end of the catheter lies for the PICC catheter as well as the midline catheter, as we just discussed. Determinants of vein selection. Solution ordered, rate of infusion. This also influences the size of IV catheters. For example, high viscosity or solutions needing to infuse quickly need larger catheters and thus a larger vein, for instance, for a massive blood transfusion. Irritating solutions also need a larger vein. Next, accessibility and condition of the vein. Be sure to visualize this to determine the ease of insertion. Is there any scarring at the site? Are the veins rolling or fragile? Location of insertion is also important to note, especially if mobility is desired. For example, an antecubital insertion site. Arm bending can cause mechanical irritation to this vein and can cause the IV to dislodge. It also affects rate of flow and can alarm the pump. Same thing with the wrists. To note as well, with the wrists, there is a risk of nerve damage here. Also, avoid foot insertion, as this requires further orders, even in non-ambulatory patients, due to that risk of thrombophlebitis and tissue damage. Additionally, you should avoid arms affected with injuries, surgeries, poor circulation, and previous mastectomies if possible. Also, avoid starting IVs on the patient's dominant side, if able. Always start distal to proximal. Hand them up. You need to know this. If you have a complication at a particular site, you can move up. You cannot move down. The early use of hand veins is important if parenteral therapy is to be prolonged. This allows each successive venipuncture to be made above the previous site, thus eliminating pain and inflammation caused by irritating fluids passing through a vein injured by a previous venipuncture. Note, this image is not appropriate as there is no clear dressing. This is important for security of the IV and infection prevention. However, note the placement of the catheter. Lower cephalic and basilic veins in the forearm are commonly used and more comfortable for patients, but do not forget the importance of starting distal to proximal for anticipated long-term need for IV therapy. Gauge and length is determined by the situation. Gauges are color-coded. The larger the number, the smaller the gauge. The ranges are 14 to 28. Larger sizes are for fast delivery or high viscosity solutions, such as trauma, surgery, and blood transfusions as mentioned. Smaller sizes are for children as well as older adult patients. The goal is to choose the smallest gauge and shortest length appropriate to the purpose. Other equipment needed for IV therapy. Solution, medication, or blood to be infused as ordered. Solutions are considered a medication. You need an order prior to infusing these. And they also come in bags of various sizes, so you need to know which one is appropriate for your patient scenario. Typically, solution bags should only be hanging for 24 hours. However, you need to continue following your facility policies, and you will hear me say that continuously in this lecture. IV tubing also needs to be appropriate to the purpose. Are you giving medications? Are you administering blood? Again, know your facility's policies on how frequent you should be changing out this tubing. You'll also need stabilization devices or tape. These prevent catheters from moving around inside the vein or from puncturing the vein. This is evidence-based practice. Pre-manufactured devices are associated with less phlebitis, infiltration, infection than tape alone. Sites may need protection from patients if disoriented, confused, or young, so be sure to know your patient and if it's appropriate or not for them to have a protective device such as a stockinette or an arm board. You need to make sure the patient has a clear dressing to allow visualization of the site, and you need to always ensure that there is sterility and change dressings when they're loose or soiled. Again, know your facility's policies and know how often these should be changed. You'll also need an IV pole to help keep the IV bag above the level of the insertion site. You never have IV bags hanging below your patient. Labels. I cannot stress labels enough. Label your solutions, your tubing, and dressings to document when it was established, by who, and when it needs to be changed. Lastly, you'll need a pump. All IV therapy should be administered via a pump. and at the ordered rate. IV solutions and body fluid compartments. Most of this slide should be review. Does anyone know how much of the human body is fluid? Approximately 60%. There are two major body fluid compartments within a multicellular organism. You have your intracellular compartment, which is fluid inside cells. This is 2/3 of the body's water. You also have your extracellular compartment, which is fluid outside of a cell. This is 1/3 of the body's water. The extracellular compartment is further divided into two areas. You have your interstitial space, which is fluid outside the blood vessels and between cells. And you have your intravascular space, which is fluid inside the blood vessels. Fluid can move between these compartments by three mechanisms. First is filtration. This is via pressure. Second is diffusion. This is movement of particles, such as electrolytes, across the membrane to equalize concentration. And then third, you have osmosis. This is movement of water across the membrane to equalize pressure. This is actually a complex process involving equalization of solute concentration. With these three mechanisms, the goal for the body is to maintain balance. To recap this complex process of the osmosis mechanism and why it plays a crucial role in how IV fluids affect the body. It is the movement of water across a membrane from an area of high water concentration, so a low solute concentration, to an area of low water concentration, so a high solute concentration, to equalize pressure. This process is driven by differences in solute concentrations. Osmosis ensures that water moves to equalize, as mentioned in that last slide, solute concentrations across a semi-permeable membrane, such as the cell membranes and blood vessels. Remember, the goal is for the body to maintain balance and for you to understand how to administer IV fluids safely and effectively, especially when dealing with fluid and electrolyte imbalances. IV solution categories. You need to know this. We are going to talk about differences between these solutions and what solutions fall under each category. My philosophy, memorization is a short-term learning strategy. If you understand what's going on, you can remember and apply it better in your nursing careers. Isotonic IV solutions have a solute concentration equal to that of blood, staying within the blood vessels and expanding extracellular fluid volume without causing cells to swell or shrink. They are used to treat fluid loss. For example, scenarios such as vomiting, diarrhea, blood loss, and shock. A great example is that normal saline is the only compatible solution for blood transfusions. Why? The equal concentration. Hypotonic IV solutions contain a lower solute concentration than intracellular fluid, causing water to move into the cells, which makes them swell and can lead to cellular rupture. Hypotonic solutions should be used cautiously, particularly in patients with heart or kidney failure. So not a solution you would ever want to bolus. A great example is D5W. It is technically isotonic, but behaves like a hypotonic solution because the body rapidly metabolizes the dextrose, leaving only free water. It also provides some calories for energy. Examples of patient scenarios include those with dehydration and hypoglycemia. Hypertonic IV solutions have a higher solute concentration than blood, causing water to move from cells into the bloodstream to dilute the higher solute concentration. These solutions should be used with caution because you want to avoid fluid overload. So also not solutions I would recommend bolusing with your patients. Examples of solutions include D5 half normal saline as well as D5 normal saline. Patient scenarios for hypertonic solutions include those with severe hyponatremia. So these solutions are used in those patients to rapidly increase serum sodium levels in patients with that low sodium. Also patients with cerebral edema. These solutions help reduce swelling in the brain by drawing excess fluids out of the brain cells into the bloodstream. And then another good scenario are patients with burns. These solutions can provide rapid plasma volume expansion, increasing that blood pressure and fluid volume. Complications of IV therapy. An infiltration is the most commonly seen IV complication. It's when IV fluid infuses into subcutaneous tissue around the IV site due to the IV insertion device puncturing a vein. It can take days for the swelling to go away depending on the size of the infiltrate. Some facilities even use infiltration scales for these assessments. Nursing interventions include prevention, so make sure your IVs are stabilized and you want to avoid starting IVs near joints. Thorough assessment is also key. Pumps do not recognize an infiltrate, so you need to use your eyes. Stop the IV and remove the device immediately. Restart elsewhere. Also, it's important to elevate the arm, if it's the arm that had an infiltration assessment, and apply warm heat according to policy. Infiltration symptoms include coolness of the edematous skin as compared to normal, edema, pallor, discomfort. The pump will continue to run until severe, note that, as well as gravity IVs will start to run slowly. You do not want the patient to get like this. If you notice the patient in the picture over here, the left hand is more swollen to the right. Rings get tight, fingers get stiff, and knuckles are not visible. Extravasation is a form of infiltration due to a vesicant solution. Vesicants are capable of causing tissue necrosis. Examples of vesicant medications include chemotherapy as well as vancomycin, which is an antibiotic. Phlebitis. This is different from an infection. Please note that. This is when the vein becomes inflamed. It's due to irritation by the IV and/or the solution. Nursing interventions include prevention. You want to make sure there is adequate stabilization of that IV, and you want to maintain correct rate and dilution of fluids, and you want to make sure you do routine site changes per your agency protocol. Thorough assessment is also key. You want to make sure you also stop the IV and remove the device and restart elsewhere. Apply warm heat according to your agency policy. Note that some facilities use phlebitis scales for these assessments as well. Phlebitis symptoms include pain, warmth, erythema at or above the insertion site, localized edema, as well as the possibility of seeing a red line along the vein's path. Note the picture on this slide. Thrombus or thrombosis. This is when a clot forms within the IV catheter or at its tip. The danger is embolization, which is dislodgement into circulation. Signs and symptoms include slowed or stopped infusions, inability to flush, as well as tenderness, swelling, and erythema if phlebitis occurs. Why else might an IV slow or flushing be difficult? Always check the clamp and/or compression of the vein. Always assess the situation first. Nursing interventions include prevention. You want to avoid interruptions in IV flow. Thorough assess, as I will continue to say. Do not ever force a flush. Stop the IV, remove the device, and restart it, as well as provide cool compresses to decrease blood flow and stabilize the clot. Again, Always assess. Blockages can also be due to a clamp or compression of a vein, as I mentioned. We talked about thrombus, so let's talk more about an embolism. An embolism is the entry of a foreign body, such as air, blood clots, broken IV catheters, into the vein, which then lodges into the pulmonary vessels. This is something that blocks an artery. This is a dramatic, sudden event and very life-threatening. Technique of IV therapy is critical, especially ensuring you complete priming of tubing, avoiding injecting air, and removing air if present. Again, don't ever force a flush. Signs and symptoms include chest, shoulder, or back pain, dyspnea, decreased blood pressure and O2 saturation, rapid pulse, as well as cyanosis. Nursing interventions include key prevention, good IV insertion technique, and maintenance. You also want to notify the provider of this stat and apply oxygen. Just a gentle reminder, if you are coming across words that you are not familiar with, I highly recommend you stop what you're doing and take the time to look these up. Local infection. This may be due to poor aseptic technique when inserting, accessing, or maintaining an IV site. Nursing interventions include number 1, prevention. This is key. Make sure there is an aseptic technique when inserting the IVs. Make sure the dressings are changed when wet or soiled, and make sure you thoroughly assess these sites. You want to remove the IV if you notice an infection and replace it in another location. You also want to change the IV tubing and the bags, as well as cleanse the area and apply warm heat according to facility policy. Signs and symptoms of local infections are all localized at the insertion site. This includes erythema, edema, warmth, pain, as well as possible exudate. Sepsis is caused by introduction of pathogens during insertion, contamination of equipment or solutions. This is very serious and is a blood-borne infection. Signs and symptoms include fever and chills, increased pulse and respirations, general malaise, confusion in elderly, as well as possible hypotension and septic shock. Interventions include prevention, the use of aseptic technique, routine tubing changes per agency protocol as well. You also want to ensure you thoroughly assess the site as frequently as needed, as well as notifying the provider. Circulatory overload is a condition where a patient receives too much fluid, which overwhelms the circulatory system's capacity. Signs and symptoms include an increased respiratory rate, abnormal breath sounds, so crackles starting in the lower lobes, bounding pulse, dyspnea and orthopnea, peripheral edema, a 1 kilogram weight gain in 24 hours, as well as distended neck veins. Let's take a moment and do a pulse check. What type of IV fluid is most likely to contribute to circulatory overload? The answer here is the hypertonic fluid, the D5LR. Isotonic fluids could also be an answer, but not the best, since hypertonic fluids are more likely to cause kidney disease, where the patient is unable to excrete extra fluid. Also, this patient would be at an increased risk for heart failure due to pump failure or outlet obstruction from stenotic valves. Allergic reaction. The following are signs and symptoms for allergic reactions to possibly anything. You need to know these at the top of your head. Please review these on your own, as I'm not going to read them aloud in this lecture. Pertaining to our IV therapy lecture, I wanted to reflect on how a patient can be allergic to even the tape. This is generally a local reaction and would need to be changed to a hypoallergenic tape. They could even be having an allergy to the medication or the catheter itself. Know that no matter what though, if there is an anaphylactic reaction, nursing interventions include stopping the IV, notifying the MD, giving Benadryl or epinephrine if ordered, and administering oxygen if needed. Hematoma, or bruising, is common, especially in the elderly and with patients who are taking anticoagulants such as Coumadin, aspirin, or heparin. A hematoma, if you're not sure what this is a collection of blood caused by internal bleeding. In IV therapy situations, this happens when the catheter punctures through the vein before there is IV fluid attached. Blood leaks from the vein into the tissues, causing that hematoma. Hematomas generally occur with unsuccessful IV insertion, but can also happen when an IV is taken out. This is why pressure must be applied to the insertion site after the catheter is removed. You want to try to make hematomas as small as possible. Hematomas may appear as a visible bruise or a lump. Regarding nerve injury, it is also possible for the IV needle to penetrate and injure a nerve, and for bruising and bleeding to irritate a nerve. Nerves are invisible from the skin surface, so it's easy to understand how this could happen. The median and radial nerves are the most commonly injured. Avoid wrists and antecubital insertions as mentioned in this lecture. Nerve damage tends to repair itself in a few weeks to a few months. Pulse check. What complications of IV therapy are applicable even when there is no continuous IV fluid running? Options include phlebitis, thrombus, local infection, embolism, allergic reactions, hematomas, as well as nerve injuries. IV therapy safety. Standard precautions in using protection from blood includes using exam gloves. Needle safety. Ensure sharps are placed into puncture-resistant containers. Never recap and always use safety needles. Always avoid taking blood pressures on IV arms. Taking blood pressures on IV arms can cause venous congestion. This can cause infiltration or backflow of blood into the catheter that can clot. Recognize key risk factors for complications. Frequent assessment is key for early detection as well, and visually inspect and palpate the site. Also, ensure the correct amount of correct solution to correct patient is at the correct rate. Lastly, compatibility of solutions with medications. Incompatible fluids or medications can cause physical or chemical reactions, leading to the formation of precipitates or other undesirable substances within the IV line or patient's bloodstream. Adverse events include toxicity, drug inactivation, as well as microemboli. Bottom line, understand why the patient is receiving IV therapy and monitor appropriately. Nursing actions to prevent IV therapy complications include having the correct insertion technique. This includes having a good IV location, sterility, not too many attempts. Most facilities only allow a nurse to try twice, and not shaving the area. Shaving actually causes microabrasions and increases the chance of infection. Clip hair if needed for dressing adherence. Nurses should also maintain sterility of fluid and port entry sites. This means scrubbing the hub for 15 seconds before you infuse anything. Also ensure that there's adequate stabilization to prevent phlebitis and/or infiltration. Change tubing per protocol to prevent sepsis. Rotate IV sites per protocol to avoid phlebitis, as well as have a correct removal technique. Focused IV assessment. First, check the order. Check the type of solution or solutions, the rate, as well as the volume. From top to bottom, you need to start with the bag. Is the solution correct that you're hanging? Is the fluid compatible with the medication? When will it need to be changed? Check the pump settings. Is the rate correct and the volume to be infused correct? Or the drip rate if using gravity? Look at the tubing. Does it need to be changed? Is the tubing compressed or kinked? Look at the site. Does the dressing need to be changed? Is the catheter well secured? Assess the site for complications. Check the color of the skin, the temperature of the skin, any presence of edema or symptoms of, presence of discharge or exudate, as well as any presence of pain. This is a nursing responsibility to note. Unlicensed personnel can only notify nurses if they notice anything. Don't stop at the site assessment. Check your patient's vital signs. Check for peripheral edema. Assess the neck veins. Does the patient report any swelling or pain or difficulty breathing? Respiratory assessment is important too, because for patients with renal or low urine input, this could be a fluid overload risk. Maybe a patient with a running dorsal IV complains of a tight ring and stiff fingers. Your first nursing priority is to compare both hands. This will start your assessment baseline. Another example, if a patient reports dyspnea, start with elevating the head of the bed and then assess for vital signs. Think of your priorities. Think of the ABCs. Correct flow rate and nursing responsibilities. If running slow, is set rate correct? Check for other reasons for it to run slow. Assess for the patency. When flushing, flush gently with normal saline. Never force a flush. Assess for infiltration. Check for flexion of extremities or kinked tubing. Make sure you maintain your ordered rate. Never increase the rate to quote-unquote catch up. Also, notify the provider. If your IV fluid is running fast, is the set rate correct? Do not change the prescribed rate. Assess the patient. Assess the lungs for signs of fluid overload is critical. Nurses may temporarily reduce the rate if complications are present. You can never increase the rate, though. And also notify the provider. IV removal. Permanent discontinuation requires an order. Removal and replacement does not. Standard precautions must be followed during removal. First and foremost, turn off the IV. Clamp the roller on the IV tubing or a big mess will occur. You also want to stabilize the catheter while moving the dressing and tape to decrease any trauma and hematomas. However, when removing the IV, do not push on the catheter upon removing. This can cause more bruising to the patient, as I stressed before. Apply pressure after the catheter is removed. Do not use alcohol upon removal. This actually vasodilates and causes increased bleeding, and it also can sting the patient. When you're applying pressure to the site, make sure you're holding for at least 1 to 3 minutes, longer if your patient is on anticoagulants. This really helps prevent bruising. Also, last but not least, always inspect your catheter tip. Pulse check. If an IV catheter is not secured well, which complication is most likely to occur? The answer here is phlebitis. This can cause an inflamed vein, as well as irritation by the IV and/or solution. Pulse check. If the pump is set incorrectly and the patient gets too much fluid too quickly, which complication is the patient at risk for? The answer here is circulatory overload, as this occurs when IV fluids are infused too rapidly or in too large a volume. IV therapy considerations for the older adult. This population has a possible decreased ability to feel pain, so insertion trauma and complications could occur, so be cautious. Their skin is thinner and has less subcutaneous fat with fewer nerve endings. Their skin integrity is easily compromised, so be careful when removing tape and have good tourniquet etiquette. Vein selection is also important. Watch for those small, rolling, tortuous veins, especially the ones in the hand. Comorbidities and physiologic changes of aging also occur for this population, so watch for their increased risk for that fluid overload, especially if they have any cardiac and renal history. Ensure appropriate and accurate volume and rate of infusion for this population, as well as every single patient, as well as have thorough and frequent assessments of the IV site. IV therapy considerations for the pediatric patient. Small everything. Small veins mean small catheters, as well as small fluid volumes and dosages. This population is pretty common for there to be scalp and foot sites for IV therapy. This population is also more prone to circulatory overload due to their immature organ functions, blood volume baselines being less, and of course, this requires frequent assessment and thorough assessment as well as all patients. The approach to starting IVs on this population is tailored to their developmental level. So stabilization using boards is possible. This helps with site protection. And also support, having peers, having parents, their parents support them during insertion. This can be traumatizing for this population and provide lots of teaching, get down to their level. Gravity flow. This is notoriously unreliable and inaccurate. This is when fluid flows by gravity through the IV tubing. The nurse manually counts drops in the drip chamber until the correct number of drops per minute are achieved. This is solely dependent on the height of the bag, the position of the patient's arm, as well as the rate set. This is largely replaced by pumps now. Here is an example of IV rate calculations. This is a gravity flow example. I'm not going to talk through this in this lecture, but please take the time to get to know this calculation. I also have provided IV calculation examples within my Blackboard shell. IV pumps. These have increased safety from reliability and accuracy. They're electronic infusion devices that are widely used, and they use positive pressure. They are more reliable and accurate than the gravity flow. They are smart pumps. They are intravenous pumps that have built-in software programmed from healthcare pharmacy databases with unit-specific profiles. They are your friend. They have alarms, and keep that in mind, especially in your pediatric or critical care units. They run in milliliters per hour. Some pumps can be set at whole numbers and 1 decimal point for very low volumes. IV infusion pump, setting the rate. Pumps run in milliliters per hour. The MD order typically states milliliters per hour, so no calculations are required. Order or protocols may state a given volume and a given time. For example, 1 liter over 10 hours, 100 milliliters over 30 minutes, or even 150 milliliters over 90 minutes. This is how you would calculate those examples provided on the previous slide. Do what works best for you. There are many ways to format these calculations. IV pump safety. Alarms. Silence but never disable. Ensure correct rate is always set, especially when you have multiple lines going. Maintain battery charge and understand the capabilities and how to use the brand of pump being used. Facilities should give you education on how to use their pumps. IV therapy. Legal implications. You need an order for IV insertions, IV solutions, rate and permanent discontinuations. Also, ensure your IV solutions are compatible. You also want to assess frequently and thoroughly. Know your medication rates, know your IV setup, label those lines, and know complications that could occur. Failure to assess means negligence. You may turn off or slow flow, never increase the flow, as well as replace an IV if complications do develop. Nurses start and maintain IVs. The role of unlicensed staff is to inform the nurse when alarms sound and to report abnormalities or patient complaints to the nurse. Follow policies of the agencies you're at and always document. If you did not document, it did not happen.